This is Ian Bodrick.
And Liang Lu.
And welcome back to the Clinical Correlation. Today's case is...
Where in the world is
Carmen Sandiego?
In today's episode, we are actually bringing you two cases. Ian just returned from a rotation in New Zealand, and I returned from a trip from South Africa. We both learned a lot from our trips and wanted to share a case each from our time abroad.
This case is a 35-year-old male with no past medical history who was sent to the ED by his primary care doctor. He went to his PCP because he had been suffering from body aches. His doctor found him to be febrile with a workup showing an elevated creatinine and abnormal LFTs.
It is important to mention here that he is a meat packer at the local meat factories, right?
That's correct. Specifically, he mentioned that he usually works with the bladders from sheep.
Looks like he was tachycardic and febrile on presentation with a normal blood pressure.
His exam was very interesting.
Wow, he is very jaundiced.
He also had conjunctival suffusion, which is a redness of the sclera without exudates.
Now you mentioned his job, so that must have something to do with his diagnosis.
Sure enough, this patient has leptospirosis. The disease is caused by the spirochete Leptospira interrogans.
Humans get the bacteria from exposure to animal urine, contaminated water or soil, or from contact with infected animal tissue.
It has an incubation time of around 10 days and requires a break in the skin or contact with mucosa or conjunctiva to enter the body.
The WHO estimates worldwide infection rates of 873,000, with almost 50,000 deaths.
Despite the worldwide burden, it is quite rare in the United States. Almost all cases are in the Pacific states, with most of these reported in Hawaii.
Risk factors include handling of meats, hiking, trekking, and triathlons.
The acute phase lasts up to a week and includes symptoms like high fevers, chills, headaches, and myalgias, which are seen in 75 to 100% of patients.
The conjunctival suffusion is very rare but characteristic. Progression of the disease can lead to symptoms like meningitis, transaminitis, proteinuria, hematuria, and uveitis.
Be aware of the constellation of symptoms known as Weil syndrome, as it has greater than 50% mortality. These include jaundice, renal failure, pulmonary hemorrhages, ARDS, myocarditis, and rhabdomyolysis.
Evaluation includes confirming with serology. This is generally a send-out test, so if suspicion is high enough, go ahead and treat the patient empirically.
Other ancillary tests that can be ordered are cultures, BMP looking for hyponatremia and hypokalemia, CBC looking for thrombocytopenia, UA for sterile pyuria, and a CK.
If a lumbar puncture is performed, you will see elevated white cells and protein with normal glucose.
Treatment is straightforward. If the patient is toxic or has life-threatening lab abnormalities, they should be admitted and given IV penicillin for 7 days.
If the patient can go home, PO doxycycline for 7 days.
And if the patient is under 8 years old, ampicillin or amoxicillin can be used.
Case 2 is a 24-year-old female with past medical history of HIV diagnosed 4 years prior. She had been on HAART, but stopped taking all her medications 1 month prior.
She complained of abdominal pain, decreased appetite, malaise, and weight loss.
Yeah, she looked terribly cachectic, dry, and was very slow to respond.
The top 2 items on the differential are systemic infections such as tuberculosis and malignancy. Does South Africa have a high incidence of TB and HIV?
One of the highest in the world, actually. Some 7 million people in South Africa live with HIV according to data from 2016. This equates to almost 1 in every 5 adults in the country being HIV positive.
Despite a global slowing down in new TB cases since 2003, South Africa recorded the world's second highest rate of new cases from 2005 onwards after Swaziland. The city of Cape Town alone has more TB each year than the US, Canada, UK, and Germany put together.
Tuberculosis is the most common coexisting condition in HIV-infected adults. It is estimated that 60% of people living with HIV in South Africa are also co-infected with TB. TB is the leading cause of death worldwide among people living with HIV.
Additionally, the risk of developing extrapulmonary tuberculosis increases as immune deficiency progresses, but this is difficult to diagnose.
That's where point-of-care ultrasound comes in handy. Using the focus assessment with sonography for HIV-associated TB protocol, or FASH exam, physicians can empirically start TB treatment by identifying signs of extrapulmonary TB while confirmatory testing is still pending. The FASH exam utilizes 6 probe positions to examine for ascites, pericardial and pleural effusions, para-aortic lymph nodes, and focal liver and spleen lesions.
In high prevalence regions, positive findings are highly suggestive of extrapulmonary TB. the presence of ascites, pericardial effusion, spleen or liver lesions suggestive of microabscesses or granulomatous lesions, and para-aortic lymph nodes are associated with odds ratios as listed.
The patient in this clinical scenario had bedside ultrasound showing lesions in the spleen, a pleural effusion, and a pericardial effusion.
Her clinical picture would have been even stronger with enlarged para-aortic lymph nodes like that seen here and abdominal free fluid suggestive of ascites.
She was admitted and started on tuberculosis empiric treatment while her confirmatory testing was pending.
To summarize, jaundice and conjunctival suffusion with a good social history can clue you into a leptospirosis infection.
Treat these infections with IV penicillin if inpatient and doxycycline if the patient meets outpatient criteria.
And use the FASH exam in HIV patients with a clinical picture concerning for extrapulmonary TB.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me @EMLLou.
Thanks for listening, and enjoy some of our photos as the music fades out.
With a taste for flavoring, her itinerary loaded with moving violations. Tell me where in the world is
Carmen Sandiego?
Tell me where in the world is Carmen Sandiego? Tell me where in the world is Carmen Sandiego? Tell me where in the world is Carmen Sandiego? Tell me where in the world is Carmen Sandiego? Tell me where in the world is where can she be? Where in the world is Carmen Sandiego? Tell me where in the world is
Carmen Sandiego.
Watch your back.